Hello, welcome back to our exam 6 review, and today we're going to be discussing antidepressants. So, as I always do, I like to start with a big picture to try to understand the concept of what we're doing. So, as we all know, the problem with depression is really low levels of serotonin, norepinephrine, and dopamine in the synapses, but really mainly serotonin that we're trying to target. So the goal is to increase the levels of serotonin and norepinephrine and dopamine in the synapses. So you're going to ask me, how are we going to increase the levels of these neurotransmitters? So the first thing that we can do is that we can block the reuptake of these neurotransmitters. So as you know, in the synapses there is reuptake receptors to kind of recycle these neurotransmitters. So the first thing that we can do is that we can block these receptors. So we can block either the norepinephrine or the serotonin reuptake. So the drugs that block the norepinephrine reuptake include the tricyclic and the antidepressants, TCAs, or the selective norepinephrine reuptake inhibitors. We can block the serotonin reuptake, so that's including drugs like also the tricyclic antidepressants, the selective serotonin receptor reuptake inhibitors, the SNRIs, and trazodone. Um, you can also block the breakdown of these neurotransmitters. So as these neurotransmitters are re up re up as they're reuptook in the synapses, they can also be broken down. And the enzyme that breaks it down is called monoamine oxidase enzyme. So we can give an inhibitor to this enzyme, monoamine oxidase inhibitor, to block the breakdown of norepinephrine and serotonin. And lastly, we have a drug that kind of works in a funky way that increases the release of norepinephrine and serotonin, which is mirtazapine. Just a side note as we start our discussion with antidepressants and antipsychotics, you will notice one thing, and that's one important concept, that one drug doesn't necessarily have one specific receptor does it target. It targets many receptors. So you'll notice that the drug has a lot of effects and a lot of side effects because it targets many receptors, and we'll see that in the upcoming slides. So the first drugs that we're going to talk about is the tricyclic antidepressants. And the tricyclic antidepressants are extremely important because you'll see them in practice, but you'll also see them a lot on exams. And I'll highlight the points that it can be targeted on exams. So first, how it works. So the mechanism of action is that it's a mixed serotonin and norepinephrine uptake inhibitors. That's the main effect for it. The other receptors that it targets is that it targets alpha 1 receptor, it targets the muscarinic receptor, and it targets the histamine receptor. And we'll see how that plays into the side effects. But I want you to understand that these are mainly for the therapeutic effect, the serotonin and norepinephrine, and these are mainly for the side effects, the alpha 1, the muscarinic, and the histamine. Use for tricyclic antidepressants is that it's used for second line depression after SSRIs and second line for insomnia. And the reason for second line, as we'll see later, is that it causes a lot of side effects. They are effective medications, but they cause a lot of side effects. They're also used for neuropathic pain, so that's pain that comes with diabetes, and they're also used for nocturnal enuresis. So just a fancy word for peeing at night, and that could be a problem with children, young children, that we can use some psychotherapy for, but we can use tricyclic antidepressants. So going down into the specific tricyclic antidepressants. So they're really, when they started making them, they made them into generations. They started kind of improving the side effect profile of these antidepressants. So the prototypical or the first generation is imipramine and amitriptyline. So imipramine is mainly used for depression, but it's also used for nocturnal enuresis. And that's the classic step one exam that they'll ask you, patient has nocturnal enuresis, besides psychotherapy, what medication can be used? And the answer is imipramine. The second first generation is amitriptyline, and amitriptyline has a lot of anti-muscarinic side effects. The biggest side effect that I would like you to be aware of is urinary retention. And the step one question or the exam question will be, patient has been recently started on an antidepressant medication, and now they're coming in with acute renal failure, for example, or they're coming in and they can't empty their bladder. And the question will be, what is the medication that they are taking? And look for the answer that has a drug with antimuscarinic side effects, and mainly amitriptyline. Second generation tricyclic is dicipramine and nortriptyline. Just to highlight, dicipramine can cause sudden death in children when used for ADHD. This is just a side note that I think your class notes kind of mentioned it. And third generation is clomipramine and doxepin, and I don't really have anything to say on it. The biggest thing about tricyclic antidepressants that I would like you to be aware of is the side effects. So side effects are the three C's: convulsions, coma, and cardiotoxicity. And the biggest one of these is cardiotoxicity. And that's why tricyclics are first dangerous, and second, they're used as second line for depression. So in addition to blocking all of the things that we talked about, the serotonin, the norepinephrine, and all the other receptors, they also block the sodium channels. And if you remember, sodium channels are found in the heart. And what happens if you block the sodium channels? What's going to happen uh, to your EKG? So the answer is that the QRS will prolong, because the QRS is dependent on depolarization. So if you block the sodium channel, QRS will prolong, and you will end up getting fatal arrhythmias. Um, Tricyclic can also cause sympathetic activation by blocking the alpha 2 receptor. Um, so if a patient is suicidal, we try not to give tricyclic antidepressants, because if they overdose on it, it can really be fatal because of this cardiotoxicity. The treatment for the overdose is sodium bicarbonate, because a lot of times patients will be acidotic, so sodium bicarbonate will um, neutralize the acidosis and will increase the secretion, or the secretion of the tricyclic antidepressants. So very important uh, point to be aware of, the cardiotoxicity. The second point, the second side effect for the tricyclic antidepressants is patients get convulsions or seizures. And the last important side effect is that patients get coma if they overdose. So cardiotoxicity, convulsions, and coma. Other side effects for the tricyclic antidepressants is that they cause orthostatic hypotension. And the reason for the orthostatic hypotension is that they block the alpha 1 receptors. And if you remember, alpha 1 receptor is found in two different places. It's in the CNS and it's in the periphery. And in the periphery, it's responsible for vasoconstriction. So if you block alpha 1, you're going to have orthostatic hypotension. You have also a lot of anticholinergic side effects, and as I talked about earlier, you get urinary retention. You have sedation from the tricyclic antidepressants, and mainly because they block histamine. You have sexual dysfunction, so problem with erections, and it's because they're anti-serotonin properties. They have some anti-serotonin properties. And the last thing is that they cause a lot of drug interactions. And the main drug interactions that they cause is something called serotonin syndrome. I want you to remember that any drug that increases serotonin causes serotonin syndrome. And bury that in the back of your mind until we talk about serotonin syndrome A little bit later, I'll make it very clear for you. But drug interaction is monoamine with monoamine oxidase inhibitors and with serotonin syndrome. So that is the highlight of the side effects for the tricyclic antidepressants. Our next agents is the SSRIs. So how SSRIs work is that they block the reuptake of serotonin from the synapses. They're used for depression, obsessive compulsive disorder, and generalized anxiety disorder. And the highlight for all of these is that they have low serotonin in the synapses. Um, how long does SSRI take to work? They take about 4 to 6 weeks, and the reason for that is that it takes some time to downregulate the receptors in the synapses. So it takes about 4 to 6 weeks to see an effect. Side effects for the SSRIs, these are actually pretty benign and safe medications, so that's why they have become popular recently. There is a black box warning for increased risk of suicide in patients that are 18 to 24 years old, so it's something to be aware of. You get sexual dysfunction because of serotonin blockade, and you also get serotonin syndrome. Again, recurring theme. Any medication that increases serotonin, that you'll get serotonin syndrome. And the main medications is monoamine oxidase inhibitors, for example, St. John's wort, or with triptans. We haven't really gone through triptans yet, but these are medications are used for headache, and they act as agonists in the serotonin receptors. So recurring theme, any medications that increase serotonin. Specific properties for SSRIs that we're going to talk about, and you might get questions on the block exam, but not so much um, on the step exam. Fluoxetine is a medication that's activating and non-sedating. So that means if you have a patient that's complaining of when they wake up, they don't really feel that they're energized, you can give them fluoxetine. Uh, Fluoxetine is a medication that has an increased suicide risk, so that has to be taken with care. And you tell the patient if you have any suicidal ideation, please report to your physician. And it also has a long half-life. Sertraline is a medication like fluoxetine is activating, so it's to be taken in the morning, but it has a short half-life. Escitalopram and citalopram, they're pretty much brothers to each other. Um, Citalopram has the least problem with sexual dysfunction among the SSRIs. And lastly, paroxetine is a medication that is sedating. So if you have a patient that's complaining of depression and insomnia, you can give them paroxetine. And fluvoxamine is really an SSRI, but I don't have anything to say about it. So we talked about the tricyclic antidepressants. We talked about the SSRIs, the selective serotonin reuptake inhibitors. Now they found that researchers they found that increased norepinephrine in the synapses also leads to resolution of depression. So they came with these medications, the SNRIs, the selective norepinephrine reuptake inhibitors. An example of these is duloxetine, venlafaxine, and desvenlafaxine, which is pretty much a brother to venlafaxine. The mechanism of action is that they block the reuptake of serotonin mainly, but they also have they block the reuptake of norepinephrine, but they also have some serotonin blocking activity as well. They're used for depression, OCD, and generalized anxiety disorder. Because they block the reuptake of norepinephrine, they also are used in peripheral neuropathy. It's thought that increasing the norepinephrine in the synapses in patients with peripheral neuropathy leads to improvement in their pain. They also have a delayed effect as the same as the SSRIs, and they have the same side effects, and they're pretty benign. The only difference in the SNRIs, because they block the reuptake of norepinephrine, you have increased norepinephrine in the synapses. And as we know, norepinephrine is a sympathetic neurotransmitter that can cause increased blood pressure. So some of these medications can cause diastolic hypertension. So you'll start a patient. A question will say a patient was started on an antidepressant. Their baseline blood pressure is 120, and now 120 over 80, and now their blood pressure is 140 over 100, for example. And the question will say, what medication has the patient been started on? And the answer will be one of the SNRIs. I hope that makes sense to you. Finally, we'll talk about some of the atypical antidepressants. And these are medications that don't really fit into one category, mainly because they block a whole bunch of things. The first medication that we're going to talk about is bupropion. How it works is that it blocks dopamine and norepinephrine reuptake. Bupropion, it's used for depression, but the biggest use for bupropion is actually nicotine withdrawal. And the reason for that is that it blocks the nicotinic acetylcholine receptor, so it helps with the withdrawal symptoms. So if you have a patient that is depressed and is going and wants to quit smoking, you can give them bupropion. Or if they're not depressed and they want to quit smoking, you can also give them bupropion. Bupropion is the medication with probably the least sexual dysfunction problems, because it doesn't have too much of serotonin reuptake. Side effects for bupropion is that it can cause seizures in patients that are anorexic or bulimic. I'm not really sure of the reasoning why, but that is a point that you could be tested on, that it can cause seizures in patients that are anorexic or bulimic. Trazodone is a medication that is also an atypical antidepressant. Mike spoke about it in the sedative hypnotic section, so I'm not going to spend time on it. Lastly, mirtazapine is one of the atypical antidepressants. How it works is that it blocks the alpha 2 receptor, leading to increase in norepinephrine. If you guys remember, alpha 2 receptor is in the central nervous system, and it decreases the sympathetic outflow. So if you block alpha 2 receptor, you're going to increase the sympathetic outflow, increasing norepinephrine. The main use for mirtazapine is two things. It's used for insomnia, so patients that have trouble sleeping, not due to the alpha 2 receptor um mechanism, but due to antihistamine properties. So it has a very strong antihistaminic properties, so it leads to insomnia. Um, and the second use, which you'll probably be tested on either in USMLE or you'll probably see in one of the question banks, is that it increases appetite in elderly or anorexic patients. So you'll have a patient who has like HIV, for example, or cancer, and you want to give them a medication that will increase appetite with not too much side effects. You give them mirtazapine. And so we talked about the tricyclic antidepressants, we talked about the SSRIs, the SNRIs, and the atypical antidepressants. And the last class of medications that we're gonna talk about is the monoamine oxidase inhibitors. Example of the monoamine oxidase inhibitors is phenelazine and selegiline. And the whole idea for these medications is that they inhibit the breakdown of monoamines. So monoamines is dopamine, serotonin, and norepinephrine. If you inhibit their breakdown, then you're going to have more in the synapses and you're going to improve um, symptoms of depression. They are used for depression, but actually the main use for the monoamine oxidase inhibitors now is Parkinson's disease, because they increase dopamine in the basal ganglia. They are used for depression, but they are last line for typical and atypical depression. I actually had a question when I was doing question banks, and the patient had atypical depression. And how are you going to know that the patient had atypical depression? Because they are reactive. Like if you try to make them happy, they will be happy. And the question was asking what medication can you give them, and I looked for SSRIs because that's the first line, and SSRIs was not one of the choices, and one of the choices was a monoamine oxidase inhibitor like phenelzine or selegiline. So know that they are used for atypical depression. Side effects for the monoamine oxidase inhibitors is serotonin syndrome. So again, any medication that increases serotonin can lead to serotonin syndrome. And again, I want you to bury that in the back of your mind until we talk about serotonin syndrome in a dedicated slide. The problem with the monoamine oxidase inhibitors is that they have a lot of drug interactions, and they are the biggest contributor to serotonin syndrome, along with other antidepressants. For example, St. John's wort. Um, so if you have a patient that you're giving them monoamine oxidase inhibitors, it's really important to tell them to avoid foods that are high in tyramine, like cheese, and wine. And I'm not sure if you remember, but we discussed it in one of the earlier review sessions. Do you guys know why we tell patients to avoid cheese and wine? Okay, so cheese and wine has a lot of tyramine. Tyramine displaces norepinephrine in the synapses. So you end up with a lot of norepinephrine buildup, and it's not broken because you inhibited the enzyme that breaks it. That leads to malignant hypertension. So hypertension that is not controlled and leads to end organ damage. So very important clinically, but also very important on test questions. They'll ask you what would you want to avoid uh, with patients that are getting monoamine oxidase inhibitors, or they'll tell you a patient is coming in. They were recently prescribed the medication for depression, and now their blood pressure is 200 over 120, and they have papilledema and they have acute renal failure. And they'll ask you what medication was the patient prescribed, and the answer will be a monoamine oxidase inhibitor. So we talked about a lot of medications. I want to give you just a summary of the treatment for depression. So the first line treatment is SSRIs because they are the safest as far as side effects, and they're probably one of the most effective. Second line is tricyclic antidepressants, but you have to be careful with the toxicities, cardiotoxicity mainly the biggest one. SNRIs is also can be used. Mirtazapine, if you have a patient who's losing weight, or if you want to increase their weight, or if you have a patient with insomnia. And bupropion is also used as a second line. Third line is monoamine oxidase inhibitors, and we talked about why they're third line for depression. This is from clinical neuro. For melancholic depression, ECT is the electroconvulsive therapy is the main stay of treatment. If you have a patient with symptoms that are worse in the morning, you want to use sertraline and fluoxetine because these medications are activating. If you have patients with symptoms worse in the evening, or if you have a patient with insomnia, you can use paroxetine. If you have a patient with sexual dysfunction, the two medications that you can use is citalopram and bupropion because these are the least sexually dysfunctioning. And if you have a patient with atypical depression, SSRIs is the first line, and then monoamine oxidase inhibitors are the second or last line. I hope that makes sense to you. We'll finish our discussion of depression and we'll go to antipsychotics. I put in a few questions um, for your educational purposes. If you have any questions on it, please let me know.